Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, who's the perfect person to be talking to about this. Because, Paul, we got to talk about common colds or upper respiratory infections, if you will. You ready?
I will. Yeah, this is my bread and butter stuff, buddy.
I figure you know something about this. So, just to define things for people, the common cold, it's benign, it's self-limited by definition, and now COVID-19 for most people is like a common cold, and it's going to be treated that way. We'll talk about isolation a little later in the video. Many patients for this can be treated over the phone or even just back and forth some portal messages. Hey, my sinuses are a little stuffy. What can I try? You know, that sort of thing. If they do make it into the office, our guest, Dr. Bird, said that if it takes like 2 or 3 portal messages back and forth, like that's where she starts to say, okay, you just got to come in. But if it's like one question, hey, what can I take for this symptom? You know, maybe you can do that with just a portal message, especially if it's a patient who's otherwise pretty healthy, not immunocompromised. If they make it into the office, the vital signs, that's really high yield, because if they have a normal temperature, heart rate, blood pressure, respiratory rate, oxygen sats, like your worry for that person goes way down. But Paul, what exam are you doing? I know you're a big physical exam guy. What do you like to do if someone comes in with this?
The thing I'm trying to rule out primarily is pneumonia or possibly sinusitis. Like, I think those are the two things that the exam might be a little bit helpful for. But much of the exam I do for validation of the patient's symptoms. If I look up in the nose and it looks awful, and then I'll be like, oh, yeah, gosh, you poor thing. Yeah, I bet you're miserable. Or I can tell that right side is more clogged than the left, or it's looking. I can tell that throat looks mean, and I think just validating the patient's symptoms so they don't feel like they're foolish for going to the doctor goes a long way when you're actually doing the counseling later on, because it feels bad to be sick, and sometimes it's helpful to remember that and actually validate that. But basically, I'm doing the exam of the organ systems that are affected. I'll look in the eyes, I'll look up the nose, I'll look in the ears, I'll look in the throat. I will also listen to the lungs, make sure there's not wheezing or any evidence of consolidation or anything that would be embarrassing to miss. But basically, I think you want to make sure that you're not anchoring to the common cold and missing something a little bit more sinister, because especially during cold season, it's very easy to be dismissive if you're not careful of those things.
What about testing, Paul? Because, a lot of people come in, they're asking me for like a rapid strep test or a flu swab. Do you think those are helpful?
To some extent, I think our guest, Dr. Bird, covered this very well in the episode. She acknowledges that they don't change management all that often. So if there's something that is, if you catch in the time course, if you actually pick up influenza early enough, certainly that is a reason to test. And same goes for COVID and someone who is high risk. That can be a benefit too. But really, it doesn't change much of what you do. It may change counseling. I liked her framing of it's important to think about your patient's exposures and who they're going to be around once you send them home. So if you have someone who's going home to someone who is immunocompromised or sick or works in healthcare, then knowing that they have the flu or knowing they have COVID becomes a little bit more important in terms of counseling, in terms of hygiene and return to work and that kind of stuff. So it may not change your management in terms of treatments, but it may change how you counsel them in terms of when they go back to work and sort of who they should talk to and that kind of stuff.
Yeah, some patients, and they just really want to know what they have. I mean, I actually can get on board with that a little bit myself, although I'm not rushing for a swab when I feel sick. I usually just try to power through. But the isolation guidelines, Paul, have been changed because, and I still get a lot of questions about this, so I think it's important to cover. But basically now they've lumped all upper respiratory infections, same kind of guidance, and kind of what we did before the pandemic to some extent. So it's like, as long as they haven't had a fever in 24 hours and their symptoms are generally getting better, they can return to, being around other people. The guidance for everyone, regardless of what respiratory infection they have, whether it's COVID or not, don't breathe in anyone's face for 5 days, essentially, Paul. But, they say, it might be reasonable to mask or make sure that there's good air circulation, that sort of thing for 5 days afterwards. I feel like that's just common courtesy with any respiratory infection.
It's stuff we should have been doing for years anyway,
right?
The COVID pandemic notwithstanding. So I agree with that.
What about the counseling, Paul? Because I think really the expectation counseling is key when you're seeing somebody with a cold. Because I feel like people feel bad and they just want you to tell them that it'll eventually go away and they will feel better again.
Yeah, well, and right. And I think you mentioned up front, just by definition, these things tend to be self-limited. So if you've made the diagnosis correctly, like this is about a 5 to 7 day course of just feeling kind of crummy. The cough can linger, and it's important to counsel patients about that. I think it's like a mean average of 18 days or something after you actually have the illness that the cough can just kind of hang on for. So people expect to be completely done with their colds when the cold is done, but you can be coughing for a couple of weeks, like 2.5 weeks after the fact. So it's good to let patients know that, and then what treatments that you offer to kind of help support them through that, but let them know that they should not be alarmed if their symptoms do persist for
Yeah.
a little bit, because that is not abnormal.
Yeah, so the treatments really you want to ask them what's their most bothersome symptom, and then you can try to target that. And we don't have great evidence for pretty much any of the treatments. A lot of the study, you might find a positive trial, but you also find a negative trial for any of these things we're going to talk about. But in general, if it's sinus symptoms, sinus congestion, our guest was talking about fluticasone, like an intranasal steroid, nasal saline irrigation tends to help, and then topical decongestants like either oxymetazoline or phenylephrine nasal spray. Oral decongestants, if they are going to take one, pseudoephedrine is what they need, and that's going to be behind the pharmacy counter, at least in the U.S., because people try to make meth with it. And phenylephrine does not work and might be taken off shelves eventually, but it doesn't work. Paul, what about if someone has more mucus or more cough? What are you looking for? What are you reaching for in those cases?
Yeah, the cough, none of the, again, as you say, Matt, none of the treatments have super heavy evidence to support them. I think there's some evidence for dextromethorphan, so it's one of those things where you can try and see if it helps. I think I really appreciate the conversation in this episode about benzonatate, which I feel like we've all prescribed because it's a prescription cough medication, so you feel like you're doing something, but the evidence is not super great. A general reminder that does come with toxicities, especially with kids, so to make sure that medication is actually secured if you do prescribe it and you counsel patients around that.
Yeah, they can
Um,
overdose on it. That is terrifying. I had no
yeah,
idea.
yeah, it can be bad. Um, so I feel like those are probably the big two. I guess it's some anecdotal stuff for galphenicin, but I don't know that. Again, the evidence is not super compelling for any of these things. So if someone feels like it helps, for me, it's go with God. But I never advocate strongly for one versus the other. I'm not sure what your
Yeah.
practice is, Matt.
I mean, I find a lot of the time it's the sinuses that are causing the cough and
Yeah.
the congestion. That's what most people are dealing with. So I'm mostly going after the sinuses. My threshold for antibiotics is basically if they have double sickening where they had a couple days, they felt bad, they got a little better, then they started to feel worse again. Or if they have persistent symptoms after 7 to 10 days, that's where I'm really thinking about an
Right.
antibiotic for 5 days, usually amoxicillin. Doxycycline would be my second line if they're penicillin allergic, and that's pretty much it. I mean, it is you really got to finesse it. And then on the episode, they do talk about some of the traditional remedies. They asked Dr. Bird pretty much every question you would have about this. So I would really recommend people listen to the full episode. If you want to do that, you can click on the link in the transcript below. And with that, I've been Dr. Matthew Frank Watto, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
And as always, I remain Dr. Paul Nelson Williams. Thank you and goodbye.